Well, it's a pleasure to give this lecture. It's probably intended more for medical audiences than lay public, but I'm happy to entertain questions at the end. And I think the gist of it is to have an idea of what tethered cord is. There's a lot that is in the literature about association between tethered cord and Chiari malformation, and much controversy has been associated with this. So I wanted to kind of present how true tethered cord is defined in the medical community, and what is it's associated with, how it is diagnosed, and what we do about it, with some information on its association with Syringomyelia. So what spina bifida in general is, it's when the dorsal part of the body doesn't form properly, meaning the spinal cord and surrounding structures, the skin, the bone, the muscles. When this happens, one of two defects occur, and this happens during the first month in gestation, so third or fourth week in gestation. This is a myelomeningocele, which is an open neural tube defect or open spina bifida. If you were to look at the top of this hill here, if you want, you will see an exposed spinal cord. So this is open. This is closed. The abnormality in the spinal cord is hidden under the skin. And the only way you can find that there is a problem is either through a skin anomaly, such as this one, or through leg problems, or through bladder problems, or through neurological problems. So this diagnosis is a bit more difficult. So this is the open spina bifida. This is the closed spina bifida. Open spina bifida is associated with a variety of different problems that includes the brain, whereas closed spina bifida, it's limited to the lower spine. There are embryological bases to each. When the spinal cord forms, it goes through two general steps. One is called primary neurulation, which is when the spinal cord forms into a tube. And this tends to lead, when there's a problem, to the open defect. Whereas the closed defects tend to be more in the secondary neurulation stage or somewhere in between the two. So now it's important to know how embryology functions. So embryological processes happen at with very strict timing, and any perturbation to that timing would result in problems with the spinal cord or with the brain. So, for example, if you were to have some kind of a drug insult during the third week in gestation, when the tube is closing, you may end up with an open neural tube defect. Whereas if you were to have the insult happen later in gestation, you may have a closed defect. This is an example of one of these closed defects. This is called the dermal sinus tract. What it is, it's a tract of tissue that starts in the spinal cord and then ends in the skin. And oftentimes you see a dimple or a hole at the skin. This dermal sinus tract can cause tethering of the spinal cord, which means it could pull on the spinal cord during development, during growth. And it may end in a tumor here called dermoid tumor. So this is just one of the manifestations of these closed spina bifida occulta defects that cause a tethered spinal cord. And in this case, as the spinal cord is closing into a tube, this is primary neurulation, there is a tract that persists where it's a connection between the skin ectoderm and the neural ectoderm or the spinal cord ectoderm, and this tract ends up presumably forming the dermal sinus abnormality I showed you. Okay, so how do we diagnose these? Well, the first and obvious issue is the skin. About half of these patients will have a skin anomaly over the midline of their back that tells you that there's a problem with the spinal cord underneath, so you need to get an MRI scan. Some present with orthopedic problems, such as a club foot or scoliosis. Some present with incontinence. Some present with asymmetry in their legs or neurological deficits. And obviously, the diagnostic method of choice is the MRI. So here is an example of the skin anomalies that we see. So on the back, you can have a tuft of hair, otherwise called hypertrichosis. It's very different from baby hair. It's coarse, it's concentrated. You can have an opening in the skin, a dermal sinus, just like what I showed you earlier. You can have a hemangioma, or just a pink staining. It's vascular structure in the skin. You can have a fat mass under the skin, subcutaneous lipoma. And look, in this case, there's also hemangioma lying over it. So these could coexist. You could have more than one skin anomaly. And that's a caudal appendage, or a false tail, if you want, just a protrusion that comes from the middle of the back. And you can have something called an atretic meningocele, which is like a cigarette burn. It's like a scar in the back. And when you see a scar in the midline of the lumbar region, you have to really strongly consider an abnormality underneath. The spinal anomalies that you see when you get an MRI are as follows. You can have a thick filum terminale, which is the string-like structure that attaches to the bottom of the spinal cord. So the spinal cord usually ends here at around L1. If it's stretched down much further, like this one, then there could be a thick filum terminale that's pulling it down. You can have a lipomyelomeningocele, which means a fat mass that attaches to the spinal cord and goes through the midline of the back to sit under the skin. And this is the mass that I showed you earlier. The sinus tract is what I showed you a schematic of before. It can start in a dermal sinus opening here and goes all the way down and attaches to the spinal cord. That can end in a dermoid tumor. This is a tuft of hair that is part of what the dermoid is made of, that's sitting in the spinal canal. You can have a split cord malformation, which is doubling of the spinal cord. You can see one spinal cord, two spinal cords, that's in cross section. And you can have syringomyelia. So the syrinx is secondary to one of these anomalies. So just like syringomyelia can be caused by Chiari malformation or a spinal cord tumor, it could also be caused by tethering of the spinal cord. These are the orthopedic deformities that we see. You can have anomalies in the vertebral bodies, you can have scoliosis, and you can have foot anomalies. Look at the asymmetry in these 2 feet. That could be significant, or it could be very subtle. You can barely see it. However, when you see these vertebral anomalies in isolation, oftentimes they're normal variants, which means that if the child does not have a skin marker, if he doesn't have problems with the legs or the bladder, and we just see this anomaly on the spine and on an X-ray, an MRI is not usually indicated. Okay, so the tuft of hair is actually something that people have known about for hundreds of years. And in fact, when you look at a mythical creature, Faun, which is a mythical creature that's supposed to be part human, part goat. So the upper body is human, the lower body is goat. One of the pediatricians at our institution went out and actually studied what people knew about Faun. And what he realized is this, if you look at what they meant by goat legs, the calves are progressively thinner. They rise on their toes to walk. The feet become rigid. They lose flexibility, architecture, and sensation of their human feet. They develop trophic ulcerations in the toes, thick layers of callus, and the gait becomes more and more spastic. Now, if we were to look at these um, uh, diagnostically, nowadays, this is a tethered spinal cord. This is a progressive deformity in the spinal cord that is causing progressive weakness of the legs, thinning, loss of sensation. So Faun, as much as we know at this point, was really based on probably a true person who had goat-looking legs and normal upper body. And this is an illustration of the tuft of hair that symbols of Faun will show. Okay, so when you have hypertrichosis, such as this child, uh, in this case, he also had foot asymmetry. So this is a baby. When we got an X-ray, we found that there's a bone that's sitting right in the middle of the vertebral body here. And when we got an MRI, we found that this piece of bone has split the cord in half. So this is a split spinal cord malformation. In this case, it was diagnosed, it was suspected when we saw the tuft of hair and the legs, and then the X-rays and the MRI showed it. So many children are born with what we call a sacral dimple. And so oftentimes we get calls into our clinic to say, you know, my child has this, what do I do about it? And so the question becomes, how do you separate something like this from a hole in the spine, like what I showed you earlier, the sacral, the dermal sinus tract? And the answer is, just like real estate, location, location, location. So if the sacral dimple is in the intergluteal cleft, in the coccygeal area overlying the tip of the coccyx, that's benign. If instead is sitting above the gluteal cleft in the lumbosacral region, and especially if there is associated other anomalies, in this case you see abnormal hair, then that's pathological. And I'll show you what this lady had in the next slide. But the difference between these is that the ones on the right happen in 4% of the normal population and don't require any imaging, whereas the one on the left always require imaging. They are susceptible to a tethered spinal cord, as well as an infection from introduction of bacteria into this hole all the way to the spinal cord. So that's the illustration. You start out in a hole, and then it travels all the way to the spinal cord. You can imagine bacteria can travel along that track. And this is what it looks like when you look at the MRI. And this is what it looks like when you look intraoperatively. That's the skin. That's the tract that we followed all the way to attach to the spinal cord. Okay. So what happens with the phylum terminale? When it gets thick, it pulls the spinal cord down and tethers it. And the treatment for this is to go in and cut the phylum terminale. But how do you diagnose these on MRI? So there are 3 criteria, and usually our standard is if we meet 2 of the 3 criteria, that's by definition a tethered spinal cord. And so in this case, the criterion are a low-lying spinal cord, low conus. So instead of L1, it might be at L3, L4, L5. In this case, this is the bottom of L3. The second is fat in the phylum. So you can see this white signal here. That's a fatty phylum. Fat is white, just like you see here under the skin. And the third is a thickened phylum terminale, which you can see here, it's quite thick. So if you meet 2 of the 3 criteria, by definition, that is pathological. But there are controversies with this, and there have certainly been situations where the conus was not low and the phylum was not particularly thick, and people have been diagnosed with something called occult tethered cord. But this is highly controversial. And these are the types of tethered cords that have been associated with Chiari 1 malformation. So it's a very controversial area that I think someone will be giving a lecture on later in this meeting. This is a paper by Tim George where he looked at the phylums, and what he identified is there are histological differences between an abnormal phylum that causes a tethered cord and a normal phylum that does not cause a tethered cord. And so this is an example of one of the many contributions that Tim has really made in these fields. Now, there are two types of hemangiomas that occur. A type that is very, that's raised, that's very dense, packed, reddish, and these are often pathological and indicate that there's a problem underneath. Whereas the faint hemangiomas, which you can see all over the body, but including the midline of the spine, those tend to be, in general, benign, with some exceptions. So usually, if you have something like what's on the left, we immediately get an MRI. If you have something like what's on the right, depending on the location, how prominent it is, we might get one of those quick spine MRIs that can give us a quick glimpse at it. All right, this is an example of the tail structure that I showed you earlier. Now, this is not a true human tail. It's not like what you see in animals, which are coccygeal remnants. They would be very low down in the spine. These happen right in the middle of the back, in the lower back, but in the middle of the back. And they can have all kinds of different tissues in them. They can have bone and cartilage and hair and nail. They could have different shapes. I've seen a picture of one that looks like an arm coming out of the back. So these are abnormalities in embryological development that you see at the skin and that indicate that there is a problem in the spinal cord underneath. This is the fat mass I showed you earlier. So this child has an accumulation of fat under his skin. But when you look at the MRI, the fat doesn't end under the skin. It goes all the way into the spinal cord, attaches to the spinal cord, causes compression, but also tethering. And those usually need to be repaired. This is an atretic meningocele, or the scar-like structure I showed you earlier, which also travels in a track to attach to the spinal cord. And this is it, attaching to the skin here and going through the underlying tissues to end in the spinal cord. That's the picture I showed you earlier, where there's a low conus from a sinus tract that's attaching to it. And here, there's a bunch of dermoid tumors and hair that are associated with this sinus tract. These can be quite difficult cases to take care of. And as you can imagine from this, some tethered cords are very simple to take care of and they don't recur. And other tethered cords like this one are very difficult. They have a complication rate and a recurrence rate. So this is a short video that I don't know if it will play, but yes, it will play, that shows that there is a dermal sinus tract that is attaching to the spinal cord. So I'm gonna, spare you the incision. We'll just fast forward through that. So what we're doing is we're following the track as we're opening the layers of the spine. And you can see the track here attached to the skin. And as we cut the dura around it, we find that the track actually ends in the spinal cord itself. So there's the tract, there's the spinal cord, and it's attaching to the spinal cord. And now this is disconnected to untether the spinal cord. And this is the phylum terminale that I told you about. In this case, we're going to cut the phylum as well. And then when everything is done, obviously we reapproximate everything and close just like normal surgery. And that's what it looks like. This is a depiction of a syrinx. So this is what a syrinx looks like on MRI. It's a cavitation of the spinal cord, which means fluid-filled spinal cord. In this case, this is a terminal syrinx, which means that terminal in the sense that it's at the terminal part of the spinal cord, the very lowest part, the conus, and that's related to a tethered spinal cord, whereas Chiari-related syrinxes tend to happen higher up in the spinal cord. So I'm going to show you, this is the spinal cord, and when you make an incision in the spinal cord in a safe area, you can look at the syrinx, you can open it, you can keep it open, or you can stent it with a syrinx shunt. But so this is what they look like when you've been told by your neurosurgeon that we need to shunt your syrinx. So there are other skin anomalies that may look pathological, but which really are not pathological in the sense that they don't coexist with spinal cord abnormalities. And those are any abnormality that's not in the midline of the back, we don't worry about from a spinal cord standpoint. Mongolian spots, we don't worry about. Café au lait spots, and hemangiomas in other locations, we don't worry about. So these are low risk. So what happens when you have a tethering of the spinal cord? Well, there are three things that happen. First, the spinal cord didn't form properly. So you might have deficits at birth because of this. You might have mass effect because of a fat mass, just like I showed you earlier, like with a lipomyelomeningocele. Or you can have traction on the spinal cord, which is what we call a tethered spinal cord. So Shoki Yamada years ago has shown in animals that if you were apply traction on the phylum terminale, meaning that you're pulling down on the spinal cord, you can cause ischemia and glucose metabolism problems in the spinal cord. And if you then release that traction, it reverses the ischemia. However, if you continuously apply traction for a long time, we know that that ischemia could become permanent, could cause a permanent problem, permanent damage to the conus. And what he found is that there could be neuronal damage, there could be impairment of metabolic mechanisms, reduction of blood flow, etc. And again, when mild, they can improve after surgery, but when they're severe, they may be permanent. And this is why we try to operate on patients with tethered cords prophylactically before they cause problems. So when do we worry? What we know about people who are born with tethered cord structures is that they often will develop neurological deficits or bladder deficits over time. So there are papers out there, natural history papers, that show that children who are born with a lipomyelomeningocele are usually continent at birth, but they become incontinent later in life. And then people with split cord malformation may develop progressive neurological dysfunction by 15 years of age. Now, the difficulty with interpreting these natural history studies is you can't generalize them to every type of tethered cord. For example, we don't know what the natural history of a tight phylum terminale is. We don't know the natural history of a dermal sinus tract is other than the risk of infection. So we have to take this with a grain of salt, and this is where the judgment of different surgeons is where the controversies arise. So you can have acute deterioration. You're not just born or develop the deficit slowly over time. It could happen after a car accident, for example. You suddenly flex your body, the spinal cord is attached, the attachment pulls on the spinal cord, you develop a deficit. And Dr. Pang has shown that very nicely in his studies. And what we do find is that it's more likely to maintain continence if these patients are operated on early rather than if one were to wait. So conclusions is that it's important to make an early diagnosis and an early treatment. There is, however, the caveat is there are controversies because not all of these tethered cord syndromes have the same natural history. Some may be more benign than others, and this is why if you ask around, you might find places that don't operate on tethered cord syndrome patients unless they become symptomatic. Even subtle midline cutaneous anomalies can be important signs to look out for that denote spinal cord abnormalities. Isolated bony anomalies without any other abnormalities in the skin or the bladder or the legs is often normal. The diagnosis is done by MRI. And most of us feel that surgery is essential in most of these children and some adults. These are rarely associated with Chiari malformations, but someone later will discuss the association and the controversies behind it. But they are often associated with Syringomyelia, and the bottom line is that, as many of you know, is that when someone presents with Syringomyelia, you need to find out what causes the Syringomyelia. So you get a full brain and spine MRI to look for Chiari malformation, to look for spinal cord tumors, to look for arachnoiditis, and to look for tethering of the spinal cord. So I'd like to thank you for the opportunity to speak, and I'm happy to take questions during the panel discussion. Thank you.